And then on this other handout here, so this is what we'll talk about when we do like passive range of motion, because when you do in the ONE2, we talked about range of motion. We do active range of motion, passive range of motion, and then active resistant range of motion. Okay, so active range of motion is when you tell the patient to move their shoulder, or move their neck, whatever. That's active. Passive is when you're doing it. And so typically passive range of motion, you're going to do it in a loose pack position. Okay, because if I go to examine your shoulder and I put it way up in here, I'm not going to be able to move that joint around very well. So if I have it in more of a loose pack position like this, I can check for the joint laxity, movement around, check the quality of the motion in the joint. So you typically do joint passive range of motion is going to be done in a loose pack position. Okay, so then we're just going to review some of the shoulder girdle muscles. We have the serratus anterior, and that's going to be C5, 6, 7. And that keeps the scapula stabilized against the shoulder, against the rib cage. Okay? What happens if you have a weakness of the serratus anterior? The scapula wings out. Okay. So the way we used to do, I had some mnemonics that we used to use to remember innervation level. And I don't know if that's really going to be that critical if that comes up on the board, but it sort of helps because we're going to be in the dermatones, myotones, right? Myotones like C5 delta, things like that. So serratus anterior is C5, 6, 7. I used to remember that because C5, 6, 7 helps you to keep you from flying to heaven, right? Wings. Whatever works, you know? Okay, so pec minor, does that cross the shoulder joint? Which joint does it cross? It goes from the rib cage to the scapula. Okay? So it doesn't go across the shoulder joint. It's not going to do anything to the glenohumeral joint, but it would affect the scapulothoracic joint. So if this is the muscle here, it's going to protract and then depress the shoulder or the scapula. And then levator scapula. Obviously, the name of that tells you what it's going to do, right? Elevate the scapula. So 3C, C3, C4. And then you have the rhomboids, and that's going to retract the shoulder, and then adduct the shoulder, which is moving it towards the midline. And then you have the trapezius. What's that?
Adduct.
Yeah. Okay. Adduction, moving it towards the center. And then you have trapezius. Okay, those are going to have, you have 3 different divisions of the trapezius. Then all 3 of them together are going to retract the scapula like that. And then the upper is going to elevate the scapula, and then lower is going to depress the scapula.
I'm sorry, what is protraction?
Take a guess. It's movement of the scapula. Would it be forward or would it be backward?
I think it's forward.
Yeah,
Okay.
protraction. You talked about that in the scapula and you talked about it in the jaw.
Okay.
I think I've got some other pictures in here that talk about the movement. I guess it would have made sense to put those first, but I don't want to change things around too much. So then you have the SCM. Oh, and then innervation to the trapezius is going to be the spinal accessory muscle, as well as with the SCM. Okay? So if the SCM is working both of them together, it's going to flex the neck. Okay? But it can, certain muscles, again, also since it inserts to the occiput like this, it could flex the lower neck but extend the upper cervical joint, right? See how, since it's pulling back here, it could do it like this. Or if you have other muscles involved that would stabilize that, then it would also be active in doing this, okay? But what if it acts one side at a time? What's it going to do? Contralateral rotation. And what about lateral flexion? Ipsilateral or contralateral? Ipsilateral. So lateral reflex to the same side, rotate to the other side. And then subclavius, it's not really that significant of a muscle, but it's below the clavicle, and it's going to help, it's going to depress this clavicle. All right, then you have the shoulder ligaments. Okay, so you can read through those. Basically, in the ligaments of the shoulder, the glenohumeral joint, it's just thickening of the joint capsule, okay? Because you're going to have the joint capsule is going to circulate all the way around the ball and socket joint, right? Then on the front, there's 3 thickenings of that joint capsule, and then that's what forms the ligaments, okay? So they're contiguous with the joint capsule. So you just have thickenings of that capsule on the front, which are the ligaments. Okay? Then you're going to have the anterior, superior, middle, and then inferior glenohumeral ligaments. So they're just thickenings of the joint capsule. They're going to be in these areas here. Okay? And then you're going to have a bursa. Okay? So the main one, you have a coracoid bursa, but usually the ones that's more significant is this subacromial bursa. Okay. So has all the rest of this stuff been on the slide so far, or the handout? Okay, so it's just that green thing. Okay. So coracoid bursa basically is going to be over the coracoid process, right? Subscapular bursa would be under the subscapularis, or on the front side here. Subacromial is underneath the acromion. And subacromial bursa is going to be in that subacromial joint. Okay? So when you're moving the joint up, shoulder joint up like this, it can get impinged.
What's the coracoid bursa?
It's be over the coracoid process.
Over the coracoid process. Thank you.
I'm assuming that's what it is because really the coracoid bursa is not really that significant. It's more subacromial bursa. Okay, so here's range of motion of the scapular movement. So this would be the scapulothoracic joint. And then also it would be the AC and the sternoclavicular joint as well. So elevation is when you're raising it up like this, and then that's going to be, like we said, upper trapezius, rhomboids, levator scap. And then depression of the scapula is pushing it down. And again, that's going to be the lower trap and the serratus anterior. So then abduction is serratus anterior, or abduction, I'm sorry. Abduction, so moving away from the midline. And then adduction is going to be trapezius and rhomboids. So then moving back this way would be adduction, moving this way would be abduction, or also protraction and retraction. So that's going to involve the sternoclavicular, the acromioclavicular, and the scapulothoracic joint. And then you have upward and downward rotation. What you use as a reference is you look at the glenoid fossa. Okay? So this is upward rotation of the scapula. This is downward rotation because we're looking at the glenoid fossa. If the fossa points up, it's upward rotation. If it points down, it's downward rotation. Okay, I'm going to have to check on that. I think the
Where's the glenoid
previous
fossa?
damage. Okay, right there.
Okay, so if that little,
It's moving up.
that thing goes up, it's up, and that little screw bearing.
It points down, so like this. This is the glenoid fossa. It's pointing down. This is downward rotation. This was upward rotation. So here's the glenoid fossa, right?
Okay.
So this would be, say, this would be my right arm. So this is upward rotation. This is downward rotation. So you're looking at the reference to the lateral part of the scapula.